Dr. Sarthak and Sports Science India for inviting me here for this talk. So I'm Dr. Dhrumin Sangoi from Mumbai, and will be presenting on anterior ankle impingement. So what exactly is ankle impingement? So it is basically some tissue obstructing in the front of the ankle which causes pain. Now the causes of this can be either a soft tissue or a bony tissue. And the soft tissues which are in front of the ankle are joint capsule and scar tissues, as you can see in the pictures. Or it can be a bony tissue which are generally osteophytes. And where do these osteophytes come from? They come from the cartilage fragments which are detached from the tibial or the talar cartilage, and they form a small round body form of thing which is an osteophyte. It can be either a traction spur, which is due to forced plantar flexion, as you see in the picture on the right, which is common in footballers. It can be an inflammatory spur. Many people with rheumatoid arthritis do have ankle synovitis, and osteophytes can form. And chondroosteophyte, as we mentioned, post-traumatic, when the cartilage knocks off. So it's commonly called as footballer's ankle or athlete's ankle. However, it is commonly seen in all types of sports, and even in ballet dancers when they go on tiptoes and dorsiflex their ankle quite a lot. Now this is the most common area of pain, which is in the front of the ankle, and that's where the ankle impinges. So you have an anterior impingement and a posterior impingement in the ankle, and the picture in the A, that is when you press, it's called as the positive impingement sign, and the patient complains, yes, I have pain. That means it is the cause. Also, we all know that the talus is broad anteriorly and narrow posteriorly. So whenever you dorsiflex, the broader anterior part which comes in contact with the tibia can cause increased forces and pain. So imaging. It is very important to get standing x-rays for all your foot and ankle patients and with pain, and the lateral x-ray is the most important to diagnose the anterior impingement. Of course, we have CT scan and MRI. So these are the CT scan pictures where you can see the dorsal talar spur. In the MRI, you will be able to see the bony edema. MRI will also help you to find out any cartilage injuries, any soft tissue lesions, and of course your ATFL-CFL ligament. So this is another picture showing an anterior ankle spur. And now the coronal image, you see a lateral hindfoot impingement. Now patients will complain of lateral ankle pain. But if you see the calcaneum, it is impinging on the fibula. So this is a flat foot patient with a calcaneofibular impingement and also lateral ankle impingement. So you have to know the cause why the impingement is happening, because just doing an arthroscopy and clearing the impingement will not work in this case. You have to correct the deformity. You have to correct the hindfoot valgus in this case to remove the impingement. So initially, to begin with, we all have to go conservative, try with eyes, NSAIDs, physiotherapy, and need to give a good trial of around 3 months if you are seeing the patient for the first time to let the pain resolve. If not, then we have surgeries. So this is a classification by Nick Van Dyke from Amsterdam, who does a lot of ankle arthroscopy work, and he divides it into 4 grades. So 0 and 1 is where your joint is normal. In grade 1, you get osteophytes. You have a good chance of arthroscopy benefit in grade 0 and 1 patients. However, as you move to grade 2, where the joint space starts narrowing, the satisfaction rate after arthroscopic debridement goes down to 50%. And in grade 3, the satisfaction rate is very low. So this is what he quoted in his paper. If you have more of arthritis, don't think of doing an ankle arthroscopy because your patient will not be happy. So it is only for early cases, which is grade 0, 1, where you know a specific impingement is causing pain and there is no joint space narrowing and the cartilage is normal. So we'll start with the case. Is a 25-year-old male. He plays football and he has a pain in foot and ankle since 1 year. These are the images not of this patient. I did not have. I just put it for representation purpose. But this is similar kind of picture which this patient had. That was anterior ankle impingement in the X-rays, CT, and the MRI. So the arthroscopy setup, Dr. Inderjeet mentioned all in detail. How do you set up a patient? So I normally use freehand. I don't use any distractor. The ankle is just hanging at the edge of the bed. So you can easily plantar flex and you can dorsiflex with your own belly. So that's how we place the ankle. It should be in a neutral, so you can give a side support or a bump under the tunicate to make sure the tibia is in internal rotation and the ankle doesn't fall off. You can use a distractor for certain cases where the joint is very tight. However, it can be done without now quite easily. So this was the young 25-year-old male. So I'll just take you through this video. It's a long video. Can we fast forward? Anyone here? Can we fast forward the video? Or can I have a cursor?
Divya, fast forward.
So this is, I'm viewing through the anteromedial joint. Play, is there a play button to fast forward? Yeah. So I'll, okay. Yeah, we can exit the slideshow and then play. 10-minute video hai iske liye. Okay, fine. Yeah. Okay, so this is the tibia, and now you can just see the osteophyte there, where my cursor is. So that was the osteophyte which this patient had and was giving him pain. So once you enter, you see a lot of synovitis. That's your talus moving down. You can see the talus cartilage moving down. And this is your ankle joint, the tibial cartilage. You see a lot of fat around which you have to clear. So going forward. So that's your shaver coming off from the anterolateral portal. Usually the bony impingements are all anteromedial and the soft tissue impingements are all anterolateral. Anterolateral you have your ATFL, you have your AITFL. And anteromedial you get the bony impingement. Why? Because whenever there is a lateral ankle instability, your ankle tilts and rotates medially. And that at the medial ankle you get repeated pressure. So there is where you get the bony impingement. So first step is to try and clear all the soft tissue with a shaver. This is a 4 mm scope with a 3.5 shaver. You get two, 3.5 and 4.5. In the knee you commonly use 4.5 shavers, but try and use a 3.5 shaver in the ankle. Always point the blunt end towards the cartilage so that you don't destroy the cartilage. Whenever you are inserting any instrument, make sure you always dorsiflex the ankle so that the cartilage gets covered and you don't injure the cartilage. So this, after removing the small spur, he had a bit of cartilage fragment as well. So that was a loose cartilage piece just below the fragment which was impinging. Now in the supine position you don't feel it impinging, but as soon as the patient is standing you have to remember that whenever the patient stands it does cause impingement. So I always use a cautery as well because the synovium will bleed, and you make sure that you cauterize all the bleeders because you don't want any hemarthrosis later. So again, check all the tissues, check your ATFL, whether it's intact, check any synovium. Again, there's a lot of soft tissue scarring there which is impinging. That's the anterolateral joint where the probe is, so make sure you have to clear that as well. And again, that's how the, so this is just that part of the work. It takes around 30 to 40 minutes to do a proper job, and once it's done, then you can close. So that was one point where we debride all the soft tissue and the bony impingement. Sometimes we have loose bodies, as is this patient.
Thank you, Dr. Sangoi. Your time is over now.
Okay.